Hello, everybody. Hopefully we got a few folks that have dialed into the live session, but we're going to go ahead and record this today. And this is basically a didactic session on malignant keratinocytic neoplasms. So I think you probably have had your lectures from possibly Dr. Vandergriff. And if you haven't, then you'll get them from somebody else. So the first case we have here, we're going to be talking about squamous cell carcinoma, basal cell carcinoma, actinic keratoses, Ka, just the kind of generic sort of stuff. And these are things that you're going to see many biopsies of in many patients in the clinic. So you really need to know that this pretty straightforward stuff. It's more practical. You'll probably see a little bit of this on the board examination, but even at this low magnification excision biopsy, so this was not a shave, this was previously biopsied, large asymmetrical lesion here, and as you go to higher magnification, and this does make kind of an interesting point because it's got kind of a basaloid morphology in some areas. It almost looks a little bit like a basal cell. If you start looking at higher magnification, it's got these areas here where there's more typical squamous differentiation. And we see that on occasion. We'll see lesions that can look like squamous cell carcinoma, maybe on a biopsy. You go back and excise it, it's got more basaloid features. So this one's a little bit in the world's most classic, obvious squamous cell carcinoma with pink cytoplasm and keratin pearls and all that sort of thing. But this was a variant of a squamous cell carcinoma. If you look down here, it looks more obvious for squamous cell. So if we see lesions that have kind of a mixed bag of squamous and basal cell type features, you want to more default towards the squamous component. So we'll often end up calling some of these lesions a squamous cell carcinoma with basaloid features if it's got something like this. But here it's obviously squamous cell. Another feature that sometimes happens is if you do a recurrent basal cell carcinoma, it will often recur and then look more like a squamous cell carcinoma in the recurrence. The other thing you want to look for when you're dealing with squamous cell carcinoma, especially more so than basal cell carcinoma, is whether there's a possibility of neurotropic spread. I don't see that definitively here, but you can see these little aggregations of squamous neoplastic cells. There's a mitotic figure here, so it's obviously malignant. It's kind of whirling in a way around. There might be something in the background here. So when you see that pattern, you always want to look to see if there's any possibility of neurotropic spread. And that's especially important when you're dealing with a lesion on the head and neck area. Not as important if you're on the trunk or the extremity, but certainly if you're on the face, scalp, something along those lines, ear, you want to make sure that you're not missing neurotropic spread. I've seen multiple lawsuits over the years as a consequence of that. If you get that, those patients generally need to be referred for possible postoperative radiotherapy. So this is an example of a squamous cell carcinoma. And notice that low magnification is large, it's asymmetrical, it's poorly circumscribed, it goes all the way down to the subcutaneous fat. So it's got all the features of malignancy, and it's also got lots of sun damage. And the vast majority of squamous cell carcinomas that we see come from sun-damaged skin. Okay, so we're gonna look at this lesion here. I think we have actually two different biopsies, and here we've got a punch biopsy, and much smaller situation here, so we don't have the broad ability to assess breadth, symmetry, circumscription, things of that nature. So we've got something that was punched into the middle of the lesion. And you can see it's got this irregular epidermal hyperplasia, and then in a couple of areas, not contiguous with the epidermis, at least here, we've got these aggregations of these atypical squamous cells with the obvious squamous differentiation, with irregular cells, hyperchromatic, there's some scattermitotic figures. So this is a punch biopsy out of the middle of a squamous cell carcinoma. So another example of a situation here, you know, again, we would like to see something that allows us to assess breadth, symmetry, and circumscription, but it's not, we do get punch biopsies of these. These are pretty good to evaluate the depth of the lesion, but not giving us a really very good ability to assess breadth, symmetry, circumscription, some of those other features. So let's look at this piece over here. Maybe a little bit of a solar keratosis residual at the dermatopathological junction, but the main changes are these areas of squamous epithelium, not contiguous with the epidermis, that are those of the squamous cell carcinoma. So you might need to, something like this, you really have to rely just on the individual aggregations. You can't use the criteria like we used in the first lesion. This one has two parts of it, so we're going to go ahead and take a look at this other piece over here. And let's look at this little area here. And notice here, we've now got a more obvious contiguity with the epidermis. So notice you've got these regular cords and strands of cells basically dissecting diffusely in the dermis. And this is a more classic example of a sclerosing squamous cell carcinoma. So again, notice the cells have a squamous morphology to them. There's evidence of intercellular bridges between the individual cells, mitotic figures. Cells are atypical. But notice you've got these very diffuse, poorly circumscribed cords and strands of cells dissecting diffusely throughout the lesion all the way to the base of the specimen. These lesions tend to behave in a much worse way. They tend to get into nerves. They tend to be more diffuse. These lesions pretty much always need to be treated by something like Mohs micrographic surgery, where you can really guarantee that you've pretty much gotten it out. If you do a routine excision, very common to get positive margins in these kind of lesions. So again, this is, we diagnose these as sclerosing variants of squamous cell carcinoma. And you always want to look to see if there's any nerve involvement when you get this pattern. The areas of nerve that we get most concerned about are the deep nerves, lesions that are generally greater, the nerve twig being greater than 0.1 millimeters in size, diameter. If they're the teensy tiny nerve twigs that we all have that give us our sensation and motor capability for things that go on up here in the upper part of the skin, those are of less importance. And the chances are, if you get a diffuse squamous cell carcinoma that's involving a large area, it's going to be wiping out those nerves anyway. So there probably is going to be some subclinical, non-significant neurotropic involvement with when you get a solid cancer that's obviously wiping everything out. I mean, it's got to wipe out the nerves too. We really get more concerned when we look down at the bottom of the specimen and see a relatively large nerve twig. We don't have any of those here. That's got evidence of squamous cell carcinoma that's in the, what looks like the perineurium. And that's really a sign, it's a manifestation of a metastasis. It means that those cells are getting into that space. It doesn't just necessarily grow like an amoeba. The cells actually break apart. They can float freely. They can get into that little space there between the actual nerve and the outer lining of the nerve. It's analogous to your central nervous system, that your CSF spinal fluid. Well, it's just a tiny amount of it in that little potential space. And they can spread as single cells and go proximal and end up getting into the cranial nerves and even into the brain. So we always comment on neurotropism, neurotropic spread if we see it. If we see a lesion like this on the head and neck area, it's a little bit of a red flag. So make sure that those lesions get treated with a more aggressive surgical modality. Okay, now we've got another lesion here. And we'll go back to lower power so we can see it. Small shave biopsy. And basically you can see there's some acantholysis here. And this is an example of a superficial shave biopsy of an acantholytic squamous cell carcinoma, okay? So we've seen warty disc keratomas before in our lectures. Here we're looking at an atypical keratinocytic proliferation. There's mitoses, there's irregular keratinocytic proliferation. There's evidence of solar keratosis off to the side. That's a helpful finding when you're dealing with an acantholytic squamous cell and the differential diagnosis between that and a warty disc keratoma. So if you see an AK that's blending imperceptibly into this kind of lesion, especially if you got a superficial shave biopsy like this, and there's a mitotic figure there, there's some disc keratosis here. So this is an acantholytic squamous cell carcinoma. Now, these lesions, some people have suggested that they tend to behave in a more aggressive fashion than other types of squamous cell carcinomas. There's a lot of literature about prognostic variables for how squamous cell carcinomas behave. I've always been a little bit somewhat skeptical of that. I've seen patients that have really ugly looking, poorly differentiated spindle cell squamous cell carcinomas that look like an AFX under the microscope when you do cytokeratin staining that's positive, and they behave very, very well. Excise them, they never get any metastases, anything like that. I've seen patients that have had obvious, classic, well-differentiated squamous cell carcinomas that are relatively superficial, just coming out of a solar keratosis, and an immunocompromised patient with a renal transplant die from squamous cell. So to me, the immune status of the host is more important than the histology. And the location can be important. If it's on the lip, mucous membrane, those lesions tend to metastasize more readily than lesions on the glabrous skin. They both can, but the host immune response, to me, is more important than the morphology. So this lesion here, I doubt seriously after this lesion was excised, the patient had any complications from it. So I'm not sure that acantholytic squamous cells superficial like this are as important. Probably more significant is the depth of involvement, if there's nerve involvement, the location, and the patient's immune status. Those are probably the most important thing. Obviously, the larger a cancer is, the worse it's going to possibly do because it's got more tumor burden. And I think that's more important than the morphology that I've experienced. So anyway, but just so you'll know, this is an example of an acantholytic squamous cell carcinoma. And here you see the obvious squamous differentiation over here. Okay. Here we've got an example of one where we get a biopsy that's taken by punch technique. And let's go this direction on it. So, oh, this is probably the way that it was supposed to look here. Not the world's best biopsy, but it's obvious squamous cell carcinoma. But notice that we've got the dermis this is epidermis. There's nothing contiguous with the epidermis here at all. There's no solar keratosis. There's really not a lot of solar damage in this lesion. We're basically just sitting here looking at a squamous cell carcinoma sitting in the middle of the dermis. And when we see that, we get concerned that it might be a metastasis of squamous cell carcinoma. Now, there's several potential reasons for that. It could be that, number one, maybe we're just not getting the lesion isn't in the plane of section. There's no epidermis in the section we're looking at, but a lot of times we do multiple cuts through this and we just flat don't see that. We just see a focus of dermal squamous cell. So we will comment when we see that is a possibility that it may be a metastasis. Now, if you look at this and you see obviously that there's a nerve involved, then it's probably a cancer that got into a nerve and is now kind of reappearing, popping up, if you will, almost like a volcano that's erupted at a different site. And it's kind of recurred because of the neurotropic spread. But a lot of times it's just like this. We just see an obvious squamous cell carcinoma sitting in the middle of the dermis, and we will ask the clinician, has the patient had a squamous cell carcinoma near this area before? A lot of times the answer is yes. Sometimes the answer is no. We recommend that they evaluate the patient to make sure they don't have lesion somewhere internally that may have spread to the skin. So if you see squamous cell carcinoma that's obvious like this with these atypical squamous cells with their mitoses, cells undergoing necrosis, we recommend making sure the patient doesn't have evidence of squamous cell carcinoma either near the site that may have spread to this lesion or possibly an internal squamous cell, say from the head and neck area, from the lung, something like that. So just always make sure if you've got a dermal squamous cell that you're making sure they don't have evidence of an internal squamous cell or a lesion that may have spread to the site secondarily. Okay, so that's squamous cell. Now let's move into the so-called precursor lesions of squamous cell carcinoma and solar keratoses. These lesions are obviously, some people call them precancers. They're really not precancers. They're really actually little mini cancers, and they're just kind of kept in check. If you actually look at the genetic profile, if you will, of an actinic keratosis like this, it's really got the same genes as a fully developed squamous cell carcinoma. P53 mutations, they have homeobox mutations, they have all sorts of abnormalities in there. So if you just look at a high magnification view of an actinic keratosis, it looks almost identical to a squamous cell carcinoma. It's really no longer the lack of contiguity with the epidermis. Cells have entered the dermis and then they have the potential to spread throughout the body. It's really that the host is keeping them in check and they just haven't had a chance to get out of the epidermis yet. And, some of them never do. They stay in the epidermis. But if you leave them alone long enough, there's a certain percentage that ultimately will end up going out away from the epidermis and ultimately can form a fully developed squamous cell carcinoma and end up killing the patient. So this is kind of an early actinic keratosis. It's kind of got a bonoid morphology, but notice that most of the atypical keratinocytic proliferation is confined to the lower part of the epidermis. So we actually developed a grading scheme a number of years ago where we said that AKs maybe behave analogous to cervical carcinoma with CIN 1, 2, and 3. Well, maybe actinic keratoses have sort of a KIN 1, 2, and 3. And this would be more like an early actinic keratosis because there's no full thickness atypia. And you do get focal full thickness atypia and actinic keratosis with time, but here we really just see lower actinic keratosis, the lower part of the epidermis, and it hasn't really spread throughout the entire thickness of the epithelium, even focally. So this would be a kind of an early lesion. It might be somewhat macular clinically, might not even be scaly. So these are the kind of lesions you kind of want to pick up early. And notice that it's relatively focal. This one's not involving the follicle. They tend to spare the follicle. If they involve the follicle in a more prominent way, well, then we, obviously kind of get a little more concerned about that. So as we go to the next case, which is this one, we'll take a look at one that's actually become a little bit more confluent over a broad front. And this one, if you look at this piece over here, is primarily an actinic keratosis. And let's see if I can straighten that up good. So notice that we've got atypical keratinocytic proliferation involving the follicle, just kind of partially spares the epidermis, involves it again, sparing, involving. You get this alternating ortho and parakeratosis in the cornified layer. So this one has got some focal areas of full thickness, atypical keratinocytic proliferation. And if this were to kind of go on over a broad front, we might go ahead and call it a squamous cell carcinoma in situ that's arisen from an actinic keratosis. So the criteria that we use is the diffuseness of involvement, whether it's involving follicles, here you're getting a little bit of follicular involvement, and if there's any acanthosis. So here you can see it's kind of beginning to form what looks like maybe squamous cell carcinoma in situ arising from an actinic keratosis. It's got an AK on the one side. That's pretty straightforward over here because it's focal, and it involves the full thickness of the epidermis only focally, and then spares the epidermis in some areas between that. So in this area, it's an obvious actinic keratosis with these buds of keratinocytes. And then we've got the areas off to the side that looks like it's beginning to form a fully developed squamous cell carcinoma in situ. So anyway, squamous cell carcinoma, the actinic keratosis can go from being just the basal cell layer, the lower part of the epidermis, to full thickness of the epidermis, only focally, then over a broad front, then we call it fully developed squamous cell carcinoma in situ. Now, Eggy Stockfleth and their co-workers, and years ago, Leonard Goldberg and Jaime Chen described what was called a proliferative keratosis. And that's where you can go from a lower, what we would call KIN1, or just actinic keratosis involving over the lower part of the epidermis, to actually getting expansion going this way, down rather than up. So sometimes actinic keratosis can progress south into the dermis without ever going full thickness of the epidermis. So you don't have to go through KIN1, 2, and 3. You can be KIN1 and then go straight into a fully developed squamous cell carcinoma. So you never really know when a squamous cell, when it is going to develop from an actinic keratosis. It can go from something like this, can it go directly into the dermis this way, or it can go over the epidermis going north, and then it can go sideways and populate the entire epidermis. So it can do kind of pretty much what it wants to. And I think a lot of that has to do with the host immune response. So once it does get into the dermis at all, you lose the contiguity with the epidermis. Then it's got the chance to spread throughout the body and end up ultimately, killing the patient. So that's basically an overview of squamous cell carcinoma and actinic keratosis. It's a simplistic overview. There's a lot more to it, if you will, than that. But that's really the generic sort of overview of actinic keratosis, squamous cell carcinoma. Now, we also have Carotid Enthoma, and this is an example of one of those. And this one's, there's several different subtypes of Carotid Enthomas. This probably would have been a really small lesion that's almost kind of warty in its appearance. But notice that it's got the exoendophytic morphology. It's got the central crater. This may be a little bit off to the side of the central crater, but it's got these bulbous, irregular aggregations of keratinocytes. And you usually in a KA will get some keratinocytic atypia. And so if you just had this area alone and you didn't have the architecture, you'd probably just call this a crateriform squamous cell carcinoma here. But when you take it and go back to low magnification and see that it's got this exoendophytic morphology, it's got the central crater, it's got some kind of verrucous morphology off to the side, it's reasonable to call this a Carotid Enthoma. And because of insurers basically viewing Carotid Enthoma now as not even being a neoplasm, as almost being kind of a cosmetic entity, I think most dermatopathologists today don't even use the term Carotid Enthoma. We call it squamous cell carcinoma Carotid Enthoma type. Now, if you get that diagnosis back as a dermatologist, you should understand that it doesn't necessarily mean that you're put in a straitjacket of having to do a surgical excision. Keratotic enthomas, especially the ones that have less atypia than this, this one's pretty atypical. This one, I think if I saw this under the microscope, I probably would recommend excision of this lesion. I mean, that's pretty atypical, and it really looks like a squamous cell carcinoma and not even a keratotic enthoma type if you just saw this lesion alone. But if you didn't see this degree of atypia and it showed more features that kind of look more like off the side here, and I'll show you like say this area, for example, or maybe over here where you get the bulbous keratinocytic aggregations like this. These are the kind of lesions that you can perhaps treat with less aggressive therapy, possibly intralesional methotrexate or intralesional 5-fluorouracil. You might even, in some cases, if you get an obvious KA and you do a shave biopsy and just kind of curette the base, that's often enough for a keratotic enthoma. So especially if you're dealing with someone like a little old lady that's got a lot of these, maybe 5 or 6 of them in a pre-tibial location, if you excise all of those, I mean, it's hard, that area is tough to close, and they get bad scars, and you may have to use skin grafts, and it's a problem. Some people even use radiation therapy on these lesions. So that's something you can think about if you get a KA that we sign out that way, that you can perhaps use a less aggressive therapy than surgery all the time. Surgery is still certainly an excellent way to do it. There are some exceptions to that. I mean, sometimes you get KAs that can actually kebnerize. So occasionally you'll excise a keratotic enthoma, and then it develops kind of almost like a cluster, like a ring of mushrooms around the original KA at the excision site, because KAs can actually sometimes develop at the site of trauma. If you get that situation, you don't want to excise those again, because you're liable to get a secondary cluster of lesions, and it can go on and on and on. So that's where you might want to think about a destructive modality. You might want to think about using a systemic retinoid in that case. And if you get a patient that's got one of the familial forms of keratotic enthoma, Ferguson-Smith, Grzyboski, those lesions, excision may not be the best option there either, because they can get thousands of lesions. So you may need to use medical treatment of KA in that situation. So let's shift gears now to look at the basaloid malignancy. So now we're going to look at obviously basal cell carcinoma. So here's a shave biopsy, and there's a whole lot of different variants of basal cell carcinoma. We're not going to go through all of those today, but this will be the classic example of a nodular basal cell carcinoma. So notice it's a shave biopsy. It's a dermal-based lesion comprised of these aggregates of basaloid cells. There's little small clefts between the basaloid epithelium here and the surrounding stroma. You often will get a fibromucinous stroma that's got a proliferation of fibroblasts in that lesion as well. And then you get the peripheral palisading of the basal cells at the periphery of the individual aggregations. So this is a pretty classic example of a nodular basal cell carcinoma. So very well circumscribed. You can see this lesion is probably going to behave in a fairly innocuous fashion. You think if you would excise this lesion, you wouldn't necessarily have to do Mohs. You might even be able to do obviously desiccation curettage, depending on the location that you're dealing with. If it's in the head and neck area, probably not. But if it's on the trunk, that'd be or extremity, a very, very good technique to treat a nodular basal cell carcinoma like this. Now, this lesion is a little different animal. And so now we've got an excision. And this one, again, and a lot of dermatopathologists, we end up using nodular diagnosis of basal cell carcinoma relatively generically. And, if you had a superficial shave biopsy of something like this, and you just saw, say, something like this is all we were presented with, this would probably be signed out as a nodular basal cell carcinoma. It is a nodule. It is a basal cell carcinoma, and we don't really know what's going on at the base if you just had a shave. But if you see this, it's got this area of nodular basal cell carcinoma. It's also got this zone where there's more of a sclerotic pattern. And this is not something that you see in the literature very frequently. Because basically, we see basal cell carcinomas that look perfectly nodular like the first lesion I showed you. But then we see some where maybe there's 90% nodular, but maybe a little bit of it looks more like this. It's kind of got a sclerotic pattern. So we'll often sign that out in our laboratory as a basal cell carcinoma with features of sclerosing basal cell in it. And, there's not any really good data to suggest that if you get that diagnosis back that those have to be treated with Mohs, or you can't do a destructive modality on that. But just so you'll realize, not everything that we see that we call that nodular basal cell is just like that first lesion. A lot of times there may be a component of a sclerosing basal cell in there, and there's not really a sharp cutoff, as which point we call it just primarily sclerosing basal cell versus mostly nodular with some sclerosis. So if you get that diagnosis back, I would probably recommend treating that a little bit more aggressively, like with surgery as opposed to D&C. But I would, or even possibly you could use radiation therapy if it was relatively well defined. But just realize that that's going to be a little different animal than that first lesion I showed you, where everything is just perfectly small and nodular aggregations. You've got some sclerotic change here. And if you saw mostly this, we probably would just call it a straightforward sclerosing basal cell carcinoma. So this lesion was signed out as a basal cell with sclerosis, not just a sclerosing basal cell, and it was treated with surgical excision, and they got rid of the whole thing. Sometimes you'll see sclerosing basal cell get into nerves. The data on what that means is not as good as it is with squamous cell, so it doesn't tend to behave as aggressively in that situation as it does when it's a fully, truly developed squamous cell with neurotropic involvement. Just realize that, but has a higher chance of recurrence when it gets nerve involvement, and you might want to think about possibly using postoperative radiotherapy. Now this lesion, even a low magnification, probably a lot of you can pick this up. This is a superficial basal cell carcinoma. And so these lesions are often multi, they have little multi, they're kind of superficial multifocal basal cell carcinomas, they have multiple foci, and as a consequence, they can be more poorly circumscribed. So a shave biopsy of this, even though it doesn't go to the margins here, you might miss an area. So you might see a little new aggregation of the carcinoma occurring over here if you did a larger biopsy. So we get a lot of requests for margins on cancers with biopsies. I'm not a big fan of that. It's okay to, we give it when the clinicians ask for it, but I would never rest my hat on that 100%, because you just don't really know for sure that, just because it wasn't in the plane of section, that maybe there's cancer either outside the plane of section that we're looking at, or that you just didn't sample it. So if you take a shave biopsy and maybe you curette the base at the time of the biopsy and you think you've gotten most of it out, and you ask us for margins and we say, yeah, it seems to be removed in these sections, perhaps you can follow the patient if it's in a low risk area, say the trunk, and you think you've gotten it out with your biopsy and maybe your local curetting. But if it's on the head and neck area, beware of that. I just be a little leery, because just because we say it doesn't seem to be in the sectioning that we're looking at under the microscope, that doesn't mean that it's really and truly removed. That's not equivalent to looking at margins bread loafed with an excision or looking at Mohs sections. So you can still have a higher propensity for recurrence if you see that. A lot of times we get these lesions sent into us as roulette malignant melanoma. Superficial basal cell carcinomas can be pigmented just like regular nodular basal cells can be pigmented. So just beware of that. So it's not melanoma. You can get that with a superficial basal carcinoma as well. So, and then one other kind of pitfall, you can get superficial basal carcinoma morphology overlying dermatofibroma, and it's not a true basal cell in that situation. Okay, so that's superficial basal carcinoma. This is an example of a basiloid neoplasm, and it looks trichoblastic in this situation. This is from an area that was non-sun exposed, and notice that it's a very large lesion. It's got multiple different sort of aggregations in it, and it's not really fully symmetrical. Each individual aggregation is surrounded by relatively normal appearing collagen, but you've got this area here that's got a cystic component. You've got the peripheral palisading of the individual cells. You might have a little bit of clefting over here. So this, to me, looks like a focus of nodular basal cell carcinoma, nodulocystic basal cell carcinoma. And then we've got these other areas that look almost kind of like they're follicular in a way. And we see these lesions on occasion, often seen in a sun-protected area, where you've got areas that look like follicular differentiation in some zones, and then areas that look more classic basal cell carcinoma in other zones. And we end up calling these lesions a lot of times a basal cell carcinoma with trichoblastic features. It's not really a true trichoblastoma, but it's in that general area. So basal cell carcinoma is an adnexal neoplasm with follicular differentiation, and it can give you a trichoblastic morphology sometimes. And when it occurs in a sun-protected area, often the scalp or the groin, often in a dark-skinned patient, they tend to behave as a low-grade basal cell carcinoma. They get larger with time, they gradually ulcerate, You want to excise them. They tend to recur if you don't get rid of them all. So we'll often call these basal cell carcinoma with trichoblastic features if they have this morphology. So it's kind of in the spectrum of a trichoblastoma, which is an adnexal neoplasm with areas of actual basal cell carcinoma that's developed within those areas. So just don't be surprised if sometimes you biopsy kind of a ulcerated fungating lesion on the groin of someone that it comes back as something like a trichoblastic basal cell. Sometimes you see even lesions that are comprised of only this type of morphology, and it may not have any contiguity with the epidermis at all. Just had a case the other day from a clinician who called me in disbelief because he thought it was a cyst. And when the biopsy, it showed the same kind of morphology. It wasn't really a cyst at all. It was more of this basal cell carcinoma with this trichoblastic morphology. If you see the basal cell, quote, carcinoma basaloid lesions in patients that have nevus sebaceous, this is kind of what they can look like. They don't really look like classic basal cell carcinomas, and we know that the vast majority of those lesions really and truly are not basal cell carcinomas. So years ago, we used to recommend excision of all nevus sebaceous lesions because they have a chance to get basal cell carcinoma within them. We're no longer doing that because we know that the vast majority of these really and truly aren't classic basal cells. They're lesions that are kind of like these trichoblastomas, if you will. Okay, the last lesion we're going to look at today is another example of a variant of a basal cell carcinoma. And here we've got this reticulated basaloid proliferation that's basically oriented in a horizontal plate-like fashion that's contiguous with the epidermis. And you've got these individual little aggregations of these basaloid cells. You've got this prominent fibrous stroma with a lot of fibroblasts and mucin. And this is what we call a fibroepithelial tumor of Pinkus. It's a variant of a basal cell carcinoma. Sometimes you actually see little areas within the lesion that look pretty much like classic basal cell carcinoma, but a lot of times you see this little primitive, these little follicular structures. And so these lesions really are probably not exactly like basal cell carcinomas. They tend to get treated like basal cell carcinomas. Clinically, they look like a skin-colored dome-shaped papule. They're often on the trunk or the back is a good location for these. When you biopsy them, they don't really feel mushy like a basal cell. They kind of feel more fibrotic, which you would expect because it's got this, this prominent fibromucinous stroma. And then basically the way to treat these is surgical excision. They're not really even usually diagnosed as basal cells most of the time. They're often sent into us as nevi or fibroma, something along those lines. But when you do biopsy them, they show this interesting morphology that tends to be this kind of horizontal plate-like architecture. Now, there are several things in the difference diagnosis of this entity, so-called syringofibroadenoma, which is a lesion with eccrine differentiation. They look pretty similar to that. If you see more follicular basaloid areas like this, that tends to favor this lesion rather than syringofibroadenoma. If you see more ductal differentiation, that would tend to favor that entity. And then sometimes we see the tumor of the follicular infundibulum that can look a little bit like this. Generally, that doesn't have as much of the basaloid elements like this, and the cells generally tend to be more squamoid because it is developing from the lower part of the infundibulum, and the cells that are more stratified squamous rather than this matrical epithelium. These lesions are probably actually neoplasms of the mantle zone, probably not of the lower part of the follicle. And you can see this, you can imagine this might have been a little primitive follicle. This is kind of what the mantle zone looks like. It's got these little buds of these basaloid epithelial cells emanating from them. And here it's just kind of gone crazy and formed this large plate-like benign, low-grade. It's not really, I guess it's not really malignant in a sense. It's going to spread throughout the body, but it's going to behave like a very low-grade process, and these present for many years, usually by the time they're biopsied. So you can think of this as a neoplasm of the mantle zone, follicular mantle. So that's fibroepithelial tumor of Pinkus. There's a lot of other variants of basal carcinoma. Morpheoform basal carcinoma, we showed you the sclerotic lesion before. It looks more like that with just kind of a diffuse pattern. You can see some where you get the really small islands of the basaloid cells over a broad front and thick sclerotic stroma that can kind of simulate desmoplastic tricho and also microcystic adnexal carcinoma. So you'll learn more about those when we deal with some unknowns and other things like that. But this is a nice overview, hopefully to supplement your lecture of some different variants of basal cell carcinoma. So next week, I'm not sure what the topic is, but we'll do it again next Wednesday at the same time and same station. And we'll have some unknown slides next week on Friday. We're doing that on an every other day basis for now, every other week basis for now. And then eventually, once we get back to live sessions, we'll go back to doing that on a weekly basis at the microscope. So thanks for listening, and hopefully it was educational for you. This is recorded. You're welcome to go back and look at it at any time you need to. Thanks a lot.